Hi, everyone. Welcome to our webinar on proton pump inhibitors. To use or not to use? That is the question. I am Dr. Jennifer Lightdale, Professor of Pediatrics at the University of Massachusetts Medical School and UMass Memorial Children's Medical Center in Worcester, Massachusetts, and I will be your moderator for today's program. Our speakers today include Dr. Benjamin Gold, an adjunct professor of pediatrics at Emory University, who is based in Atlanta, Georgia, at the Children's Center for Digestive Healthcare. Dr. Rachel Rosen, assistant professor of pediatrics and director of the Aerodigestive Center at Harvard Medical School in Boston, Massachusetts. Dr. Jose M. Garza, an adjunct assistant professor of pediatrics at Emory University, also based in Atlanta, Georgia, at the Children's Center for Digestive Healthcare. And Dr. Carlo DiLorenzo, who is professor of pediatrics at The Ohio State University and Nationwide Children's Hospital in Columbus, Ohio. We also wish to acknowledge Dr. Henry Lin at the Children's Hospital of Philadelphia, who served as our CME content reviewer on behalf of NASPGHAN. Thank you especially to NASPGHAN and the NASPGHAN Foundation for sponsoring this webinar, which has attracted a lot of attention, and to AstraZeneca, which provided support for this program. I'm going to start with some quick housekeeping points. Our presentation today will be case-based, and at the end of each presentation, total presentation, we will take as many of your questions as time will allow. But please don't wait until then to submit them. You may send in questions at any time during the webinar. The question area is located directly beneath the webinar player window. You may need to scroll down to see it. Also beneath the webinar window is a link to the registration page, which contains directions on how to obtain CME credit. Yet another link beneath the webinar window allows you to download the slide deck in a PDF format. So let's begin by discussing the objectives and rationale for this webinar. Next slide. As I think we have all been aware, there's been a tremendous rise in the use of proton pump inhibitors, or PPIs, in children over the past 15 years. And this has particularly been an issue in infants less than 12 months of age. Needless to say, there has also been a growing preponderance of evidence that PPIs do not reduce reflux symptoms in infants or decrease infant crying and irritability. Next slide. Having said that, I think as pediatric gastroenterologists, we know that PPIs are extremely effective at acid suppression. They are also the preferred treatment for a number of acid-related disorders. And generally speaking, compared to many medicines we use as pediatric gastroenterologists, they are relatively safe. However, there have been growing concerns with the risk of PPI utilization. And I think it's becoming even more important for pediatric gastroenterologists to know pediatric indications of when to use and when not to use PPIs, as many people are asking us this. We also need to remember and go over the recommended durations of use. Next slide. We've really designed this webinar with the objective of discussing an evidence basis for using versus not using PPIs in children. Due to time constraints, this is going to be a very high-level discussion. Indeed, I think it was hard for many of us on the faculty to really step back and say, what are the important points that need to be made? How do we achieve balance in our discussion around PPIs? And how do we make sure we really discuss evolving concerns and how we're going to work with them as pediatric gastroenterologists? And again, this is a webinar intended for pediatric gastroenterologists. I think ongoing work will involve trying to adapt some of this content for pediatricians. Next slide. The learning objectives of the webinar are really to start to make sure everyone on board is able to differentiate between non-erosive reflux disease, or NERD, from erosive reflux disease, functional heartburn, and hypersensitive esophagus, and talk about what we know about that now. We also want to make sure people walk away understanding the pathophysiology for extraesophageal associations for reflux disease and when there is causality versus suspected associations. As a third learning objective, we want to understand indications for when PPIs should be prescribed, as well as what to do when PPIs don't work. And as a fourth objective, we certainly want to discuss the risks of treatment, as well as why, when, and how to stop treatment. Next slide. I am joined by a wonderful faculty, and they will be taking you through this ambitious agenda. And we're all going to be introducing the next person, so it's a bit of a relay race. So with that, I'm going to turn it over to Dr. Rachel Rosen to take us to NERD and beyond.
Thanks, Jen. So we're going to start with a case. The first case is a 13-year-old with epigastric and chest pain. There's a history of 3 years of PPI use, initially with complete symptom resolution, but now only with partial relief with symptoms multiple times per day. The patient had an endoscopy 3 years ago, and it was repeated last week, and it was normal with biopsies in the duodenum, stomach, and at 3 esophageal levels. Next slide. The section objectives are to understand how to differentiate non-erosive reflux disease from erosive reflux disease, functional heartburn, and hypersensitive esophagus. We are also going to go over how to diagnose NERD and how to treat it. Next slide. So the old definitions for NERD are when there were no erosions on endoscopy, abnormal acid reflux burden by pH probe, and classic reflux symptoms of heartburn. But the definitions have changed quite a bit over the last several years, and I'm going to go over those as shown in the table below. So as I mentioned, erosive reflux disease patients have typical symptoms. They have erosions endoscopically. They have abnormal acid reflux burden by pH impedance probe, and they may or may not have a symptom association with their probe. In contrast, non-erosive reflux disease patients have typical symptoms, no erosions endoscopically, an abnormal acid reflux burden by pH impedance probe, and again, they may or may not have a symptom association. Hypersensitive esophagus is a patient who has typical symptoms, no erosions by endoscopy, a negative acid reflux test, so no pathologic acid reflux, but they do have a positive symptom correlation with either acid or non-acid reflux. And then finally, there's a new category of functional heartburn, where patients have typical symptoms, no erosions by endoscopy, normal acid reflux burden, and there's no correlation between their symptoms and either acid or non-acid reflux. Next slide. When we look at the subtypes of these and the prevalences, it's very helpful to note that almost half of patients have a diagnosis that would not respond to proton pump inhibitors. So according to the adult values, 40% of patients have true non-erosive reflux disease. 20% of patients have a hypersensitive esophagus with acid as a cause for their symptoms. 15% have a hypersensitive esophagus with non-acid reflux associated with their symptoms. And then finally, 25% have functional heartburn. Unfortunately, there's no pediatric studies that look at this prevalence to suggest whether these proportions are the same in children. Next slide. The mechanisms of non-erosive reflux disease are the same as with all types of reflux disease. The main mechanism of reflux is the transient lower esophageal sphincter relaxation. On the right side of your slides, you can see that there's a high-resolution manometry tracing with impedance. So just to go over the tracing, you see a yellow bar on the top of the slide, and that's the upper esophageal sphincter. On the bottom of the picture, you have a red bar, which is a lower esophageal sphincter, and you can see purple, which is liquid by impedance. What you notice is there's relaxation of the lower esophageal sphincter with purple or liquid moving up into the esophagus when the sphincter relaxes. When you look at patients who have NERD, they have very similar symptom severity to those with erosive reflux disease. And similarly, they have the same rates of visceral hypersensitivity. So when you instill acid into the lower esophagus or you instill saline into the lower esophagus, patients with NERD and erosive reflux disease feel the distension and the pain in exactly the same manner. Next slide. So for diagnosing NERD, how can we tell the difference between NERD versus erosive disease? Well, we can't use symptoms. So when you look at the values, heartburn, regurgitation, epigastric pain, and dyspepsia are all similar in NERD and erosive reflux disease patients. Similarly, both of these groups respond equally to proton pump inhibitor trials, so you can't use a trial to make the diagnosis. And finally, when you look at your microscopic evidence from your biopsies, what you find is that both erosive patients and non-erosive patients have similar amounts of microscopic inflammation, and they both have dilated intracellular spaces. And when you look at the picture on the slide to the right, you can see a picture of the cells, and you can see the blue lines, which show you the dilated intracellular spaces. Next slide. So now the management algorithm and how to make the diagnosis. So this is an algorithm that's been put forth by adult gastroenterologists, and I just want to go over it because it shows the role of proton pump inhibitors, but also the importance of testing in these patients. So when you start at the top with patients who have burning or chest pain, if they have any alarm symptoms, they go to endoscopy. If they don't have alarm symptoms, they go on to double-dose proton pump inhibitors. Now, just to highlight what's in the green circle, if you have an endoscopy and you have inflammation grossly, you would fall into either the erosive esophagitis group or the eosinophilic esophagitis group. If you have a negative endoscopy, you again go into the double proton pump inhibitor trial. If you respond to proton pump inhibitors, you get classified as GERD. If you don't respond, that's when you go to pH impedance testing. And it's important to note that in this algorithm, they are recommending testing off of therapy. This is really important because the yield of testing of reflux is higher when you're off therapy. So then, once you get your testing, you get categorized as either positive or negative. Positive means either an abnormal acid exposure or a positive symptom association, and then you get a diagnosis of NERD. Notice that hypersensitive esophagus falls into this category too. In contrast, in the red circle, when you have a negative pH impedance study, normal acid exposure, and a negative symptom association, you fall into the functional heartburn category. Next slide. So why do we care about this? Is it just about the name? Well, the answer to that is no, it doesn't seem to be. So I'm going to highlight first what's in this first circle, which is how do NERD patients and hypersensitive esophagus to acid patients respond to PPIs. If you're going to have a patient who's going to respond to a PPI, it's these two categories. And the current recommendation is to use single or double dose proton pump inhibitors for patients with NERD or hypersensitive esophagus to acid. Also on the table are motility medications like baclofen, which reduces the transient relaxation of the sphincter, but also fundoplication. In contrast, in the next circle, what you should notice for hypersensitive esophagus to non-acid reflux is that these patients really don't respond to antacids. So you don't, if you have a patient who has this, want to add more proton pump inhibitors or H2 blockers. The treatment for this group is either motility medications or surgery. Finally, in the last circle, if you have functional heartburn, these patients don't respond to proton pump inhibitors at all, and they make up a very good proportion of the population. So in these patients, what you want to treat with is tricyclic antidepressants, or SSRIs, not add more proton pump inhibitors. When you look at the response of these functional heartburn patients to SSRIs, what you find is that up to 60% have complete resolution of symptoms on an SSRI, compared to about 30% in the placebo groups. Now, interestingly, a new study came out in the last week looking at imipramine for the treatment of functional heartburn and hypersensitive esophagus, showing no benefit for symptoms, but the jury's still out. So next slide, our case review. So our patient had an impedance study off therapy and had 45 reflux episodes, which is normal, and a normal pH portion of the test. But 6 out of 6 chest pain episodes were associated with reflux. So this patient has a diagnosis of hypersensitive esophagus. They went on twice-a-day acid suppression, and citalopram was added for reduction in pain frequency and severity. Next slide. So to summarize, functional heartburn and NERD, definitions of NERD, erosive reflux disease, and other conditions are changing, and these definitions are critical to understanding the role for potential therapies. One of the primary indications for impedance testing off therapy may be to differentiate NERD from functional heartburn. And finally, acid suppression has a role for the treatment of NERD and hypersensitive esophagus when related to acid, but not to functional heartburn or for the treatment of non-acid reflux. So now I'm going to turn this over to Dr. Gold, who's going to talk about the aerodigestive conditions and associations with reflux.
Thanks, Rachel, and good evening, everyone. My task this evening is really to try to present the case of association versus causality, and hence the title, Aerodigestive Conditions and Associations with Reflux. Next. We're going to start off with a case that hopefully highlights some of the clinical dilemmas that we face in everyday practice when we're dealing with children where reflux is blamed or inferred as causing the disease by the otolaryngologist or by the pulmonologist. This is a 6.5-year-old with a persistent cough that was occurring both in the day and night. The patient, according to his mother, had noticeable increase in his wheezing episodes, particularly over the past year. His past medical history, at least as defined by the mother interpreting the pediatrician, was that he had GERD as an infant, and this was diagnosed after he presented to the ER with an acute life-threatening episode. Currently, he's using PPI therapy once a day. Next. So in this section, what I hope to overview for you is the pathophysiology of common aerodigestive associations with reflux. And the key operational term here is associations. Association does not imply causation. Second, to describe the evidence that infers a biologic plausibility for the aerodigestive condition and reflux. And finally, when it might be appropriate to use a PPI for extraesophageal conditions that are associated with reflux. Next. It's important to have a basis operation understanding of airway protective mechanisms. And if you remember from embryology, the airway system and the digestive tract start from the same embryologic origin. So in fact, sharing common innervation and common neural pathways, it's easy to see how the two systems can somehow be connected. So to start off, if you sort of use as orientation the figure on your left, there's esophageal distension and the upper esophageal sphincter contracts. Next, there are vagal reflexes where the vocal cords close, central apnea occurs, and the upper esophageal sphincter relaxes. Subsequently, refluxate enters the pharynx, and then swallowing clears the pharynx, and finally respiration resumes. So there's normal physiologic apnea that occurs as an aerodigestive or airway protective mechanism in normal swallowing. Next. So this talk is my portion is going to focus on 3 or 4 major parts of the aerodigestive associations. And this first section focuses on asthma and reflux. And the question to ask yourself is association or causation. There are a number of proposed mechanisms by which reflux aggravates asthma, and some that have been listed are direct production of airway inflammation, airway hyperresponsiveness, neuronal-mediated inflammation, as well as vagally mediated bronchial or laryngeal spasm. There have also been studies that evaluated the impact of asthma on GERD. So if a patient has chronic hyperinflation due to moderate to severe asthma, this may reduce the resting LES pressure and predispose the patient from chronic reflux. In addition, lung hyperinflation and airway flow obstruction may increase negative intrathoracic pressure, which in turn predisposes the patient for increased reflux. Next. This slide, which you're going to see 2 other times during the course of the presentation, I want to bring your attention to the bottom part. A group of studies that were evaluated and analyzed in adults. And in particular, I want you to focus on the 3 aerodigestive conditions: chronic cough, hoarseness, and asthma. And you see where there's placebo in the first column, and then therapeutic gain, that's highlighted by the brown horizontal bar, and therapeutic gain, the blue, in the latter 3 quarters. And you can see with chronic cough, there really doesn't appear to be a major improvement, except for those that are pH negative. Hoarseness did not improve, and asthma, actually, there was a negative response. Next. 2 randomized multi-center placebo-controlled trials, one done in adults, the New England Journal article conclusions, which are shown on the left in this slide, and a JAMA article done by the pediatric portion of the Asthma Lung Consortium shown on the right, highlight really the dilemma that we face as clinicians. In both studies, both in the adult study and in the pediatric study, either omeprazole or lansoprazole did not improve asthma endpoints. So remember, in this study, adults in the esomeprazole trial or pediatric patients in the lansoprazole trial were put on either placebo or high-dose acid suppression, and asthma outcome variables were studied. And in both studies, the acid suppression agent, the PPI, did not improve asthma outcomes. However, if you read through the methods and in particular the results, in both of these studies, there were a subset of patients that did improve. And I think the key that was provided in the discussion from the authors of both of these manuscripts is identifying those patients. So GERD and asthma, well, the saga continues. There's clearly biologic plausibility, but causality at next is not yet proven, and more research is needed. Next. So what about cough? And the neurophysiology is shown here, and I think 3 take-home points. So the figure on your right highlights the physiology or the neurophysiology of cough, and 3 take-home points for you to recognize, which really do present the dilemma for the clinician, is not every child who coughs or wheezes has asthma, and more importantly, not every child who coughs or wheezes has reflux. And other conditions such as dysphagia, aspiration syndromes, and other etiologies such as habitual cough need to be considered. Next slide. It's also important to recognize that these are the children in which testing may be clearly indicated. In particular, this tracing done by our first speaker, Rachel Rosen, which demonstrates that a particular technique called intraesophageal pressure recording, it's very sensitive at detecting cough. And just as we see with eosinophilic esophagitis or with erosive reflux disease, symptoms don't always correlate with disease. And in this particular case, and highlighted by this study published by Dr. Rosen and her group, parental and patient symptom recording in children is inadequate for making the diagnosis of reflux-associated or related lung disease. And so intraesophageal pressure recording may represent a new standard for clinical practice. Next slide. So with respect to cough and reflux, well, still a possibility. Biologic plausibility, clearly. Causality, likely multifactorial. And in this case, there may be a role for a PPI in select individuals. And where we really have the onus now is to do the specific research studies that identifies those key individuals that will respond to acid suppression. Next slide. So what about ENT manifestations of GERD, and have they met the burden of proof for causality? Next slide. We've all experienced the referral from the otolaryngologist who does the intra-office nasal laryngoscopy in the child with recurrent pharyngitis, recurrent cough, or recurrent sore throat, and they see red. They put the child on nuclear doses of PPIs. The patient comes back to the ENT doctor, and this is no disparage comments about my ENT colleagues, many of whom are my good friends, but the fact is that the child's symptoms are still there, the child's throat is still red, and they say, oh, it's got to be reflux, so there must be something that our gastroenterologist can do. And so we get the referral, and we're supposed to figure it out. In this slide, to sort of highlight that dilemma that they face, on the left is a perfectly normal voice box, if you will. So in the center, the 2 vocal cords, down near the bottom of the panel, the arytenoids, and at the top, the epiglottis. Nice pale pink mucosa, easily distinguished vascularity. And on the right, beefy red arytenoids, clearly swollen and exudative vocal cords, and a beefy red epiglottis. That's got to be reflux, right? Next slide. So the sensitivity of laryngoscopic findings to identify reflux is poor, and in fact there are no good validated scoring measures, particularly in pediatric patients, for the visual assessment of the acuity of laryngeal-pharyngeal reflux, or LPR, or LERD for short. There has been some studies, more in adults, that have showed clinical improvement by recurrence off treatment, suggesting an association with GERD. And there's insufficient evidence to recommend for, or more importantly, against the use of acid suppression therapy in these patients. Next slide. So with respect to ENT manifestations, clearly a biologic plausibility. The evidence is there in both human and animal models. Causality, well, not at present. More research with validated endpoint variables are necessary. And is there a role for PPIs? Well, maybe. Next slide. And finally, a group of patients, which I think above and beyond all that I presented in my part of the section, clearly merit our attention and long-term follow-up. And in particular, if you have the access to a multidisciplinary center, such as the one led by Dr. Rosen, these children merit an evaluation. And those are the children with esophageal atresia and tracheal-esophageal fistula. These children can have symptoms that include coughing with feeding, recurrent pneumonia, episodic cyanosis, and oftentimes can present to the emergency room with suspected ALTE. A specific type of TEF, that is the H type, are prone to delays in diagnosis, can't be identified by fluoroscopy, and may require bronchoscopy with methylene blue to see the fistula. They're very predisposed to reflux. I mean, the bottom line is when the esophagus is a blind pouch, even when connected, the motility, motor function, and the propagation of the bolus is definitely abnormal. So abnormal motility is going to prevent adequate acid clearance. And oftentimes the hiatal hernia created during repair changes the position of the LES in the diaphragm. And a meeting that's going to be held this September in Sydney, Australia, it's going to be the fourth, organized by both parents and clinicians and scientists, clinicians as well, is the long-term risk for esophageal cancer in those children with esophageal atresia. Next. So with these group of patients, clearly a biologic plausibility for reflux-induced disease. Causality meets all the criteria. And is there a role for PPIs? Yes. Next slide. So in summary, aerodigestive disease and reflux, are they related or are they just associated? Well, reflux causality has not yet been satisfied for asthma, for cough, and laryngeal disease. Clearly, a hot topic and more research is needed with multidisciplinary collaboration in childhood asthmatics. And what I think the take-home point from those studies published in adults in the New England Journal and in children in JAMA is we need to identify those children with asthma who are clearly responsive to acid suppression. There may be a role for the PPI in cough and select laryngeal-pharyngeal reflux patients, and clearly there's a role for the PPI in infants and children with esophageal atresia and tracheal-esophageal fistula. So at this point, I'm going to turn it over to my colleague, Dr. Garza, who's going to go through evidence-based indications for treatment with PPIs.
Thank you very much, Ben. Good evening, everybody. I'm going to talk about the evidence-based indications for the treatment with PPIs. We're going to start with a case. 12-year-old male has a 2-year history of intermittent epigastric burning sensation, regurgitation, and dysphagia. He's been treated with over-the-counter antiacid medications providing minimal to no relief, and we proceeded with endoscopy, which we can see in the picture that shows mucosal edema, furrowing, as well as white exudates. Biopsies from the mid and distal esophagus as well as proximal showed basal cell hyperplasia and greater than 15 eosinophils per high power field. So what are the section objectives? We're going to talk about when PPIs should be prescribed. If the eosinophils in the case that we presented are a 12-year-old found in the esophagus, does that indicate that the patient has EOE? What is more indicative of erosive disease? Is it endoscopic or histological findings? And what do we do when the PPIs don't work? So we're going to start by discussing that PPIs now play a key role in the diagnostic evaluation of a patient that has esophageal eosinophilia. Because not all esophageal eosinophilia is EOE. We have there patients that have EOE, patients that have EoE and also have associated gastroesophageal reflux disease. But there is a subgroup of patients that have an EoE phenotype in which they have exact same symptoms and histopathological findings, but with the big difference that they actually completely respond to PPI therapy. And these are the non-GERD PPI responsive esophageal eosinophilia. On the next slide, we see that at least a third of adult patients that have suspected EoE, both by symptoms and histological findings, they both achieve full remission on PPI therapy. This has been shown in children as well, and we think that the response is a little bit more limited, but more research is needed. Treatment includes high-dose PPI for at least 8 weeks, which is going to be followed by endoscopy and biopsy to prove that the eosinophilia responded or not. We're moving on to the more evidence-based indication of PPI, which is healing of the esophageal lining. The endoscopically visible breaks in the distal esophageal mucosa are the most reliable evidence of reflux esophagitis. But it's important to remember that the absence of histological changes does not rule out gastroesophageal reflux disease. When we look at the next slide, we can see this is the same slide that Dr. Gold showed, but we're going to focus on the top part of this. On red is the effect of placebo, and on blue is the therapeutic gain. And we can see that PPIs show an amazing therapeutic gain for healing of esophagitis, both mild and severe. As well as when we're talking about heartburn relief of esophagitis, as well as when there's no esophagitis and we're talking about NERD patients. When we talk about chest pain, the therapeutic gain is going to be big when it's associated with positive pH probe. But what about pediatrics? So we can see in the next slide that the effect of lansoprazole on erosive esophagitis in children, this was between 12 months and 11 years of age, open label, multi-center study, patients that had symptoms of GERD and have erosive esophagitis by EGD. They were given either 15 milligrams or 30 milligrams, and if they were not responding, they were allowed to increase up to 60 milligrams a day. And we can see that by week 8, 78% of the patients achieved healing, and it was 100% of the cohort achieved esophageal mucosal healing by week 12. And moving on, we can see also that a study done by Hassal on omeprazole, also open-labeled, multi-centered, this time 1 to 16 years of age, showed that 54 out of 57 patients that have erosive reflux disease showed complete healing of the mucosa after the trial, which we can show that this is similar to the healing rates in adults. But what about infants? So esomeprazole has been studied and was approved for healing of erosive esophagitis in patients younger than 1 year old and as early as 1 month of age. And we can see in this graph, in the y-axis is the percentage of time in which the intraesophageal pH was less than 4. And they were divided by 2 doses, 0.25 per kilo and 1 milligram per kilo. And we can clearly see that there is a dose-related acid suppression response in infants. But what's important is that all infants tolerated the medication well. And on the next slide, we can see the FDA-approved pediatric age ranges and indications for each individual PPI. On blue, we can see the indication for healing erosive esophagitis, and on light brown, we can see the indication for symptomatic GERD. But what about other indications for PPI? Well, how about NSAIDs? So when people are taking nonsteroidal anti-inflammatory drugs, they should be on prophylactic PPI. And at least in adults, patients that have poor adherence to PPI therapy when they're on NSAIDs have an increased risk of upper GI complications when they're compared with those who are fully adherent. The risk of an event is increased by 6 points for every 10% decrease in PPI adherence. Next slide. When we're talking about an inpatient that has gastrointestinal bleeding, IV PPI is going to be given in almost all instances. The evidence from Cochrane review suggests that PPI therapy in this setting represents no harm and may provide some benefit. So, treatment of PPIs should be used for the diagnostic evaluation of esophageal eosinophilia if a patient is given high dose for 8 weeks followed by endoscopy and biopsy and they have resolution of their eosinophilia. They are PPI responsive esophageal eosinophilia. If they have erosive esophagitis, we give standard dosing for at least 3 months, and at that point, based on symptoms, we'll start tapering the dose towards a final withdrawal of therapy. When patients are taking NSAIDs, a standard dose of prophylaxis should be given concurrent with the NSAIDs. Bleeding in the hospital, IV 1 milligram per kilo once a day or half a milligram per kilo twice a day. And of course, remember that PPIs are part of the quadruple or triple regimen for H. pylori, standard dose BID for 10 to 14 days. And on the next slide, I want to highlight the importance of proton pump inhibitors in gastroesophageal reflux disease. We can actually divide the disease before PPIs and after PPIs, because before PPIs, the therapeutic challenge was how to achieve mucosal healing. Managing the ulcers, the erosive esophagitis, as well as the recurrent strictures with only antacids or H2 blockers was very difficult. But now, the therapeutic challenge has shifted. How do we deal with the refractory symptoms when the patient has failed PPI? And after the era of the PPIs, the list of symptoms and syndromes that are potentially attributable to GERD have expanded. So on the next slide, we see what do we do when this PPIs don't work. Well, we need to assess for treatment compliance. The actual lack of efficacy in the gastric acid secretion of a PPI is extremely rare. So we want to make sure that the patient is taking the PPI on an empty stomach at least 30 to 60 minutes before a meal. We can also try BID dosing. We can also try to add an H2 blocker at night if there's night symptoms and the patient is taking it during the day, although over time, because of the H2 blocker, there's going to be some tachyphylaxis. And most importantly, if the above has failed, we want to make sure the diagnosis is correct. And referring to the lecture by Dr. Rosen and Dr. Gold, where there is a lot of GERD attributable symptoms that are not responsive to PPI, like functional heartburn. So, in summary, indications for PPIs are indicated in GERD, nonsteroidal anti-inflammatory drug prophylaxis, bleeding, the algorithm for esophageal eosinophilia, as well as H. pylori eradication. Now, it's important we're doing this through a specific course of treatment for a defined duration of the treatment with a weaning plan in place, and the ongoing management should always include with the patient and with the symptoms a review of plan for treatment discontinuation. And with this, I want to present our next speaker, which is Dr. Carlo Di Lorenzo, which is going to talk to us about understanding the risk of treatment with a PPI.
Thank you. Thank you, Jose. Good evening, everybody. So my charge is to discuss the risk of treatment, and that's probably the most recent part of the literature. You know, all the things we've heard from the previous speakers have been debated in the literature for many years, but the risk of the treatment is coming from literature that is very published in the last few years. So let me start with the case, like everybody else has done. A 9-year-old boy is diagnosed with erosive esophagitis when he presents with an episode of hematemesis. He's treated with the PPI BID for 12 months. Most of us will probably go that route with BID because of the severity of his initial presentation, and then he becomes asymptomatic. Now the parents come to your clinic and want to know if and when they can stop treatment. Now, interestingly, when I looked at the answers given by all of you who have done the pre-test question, most of you agreed with this one. About 2/3 of you suggested that it's time to wean the treatment. And I fully agree with that. So let's see how and when and why should we do that? In fact, that's the section objectives, is to understand why to stop the treatment, when to stop the treatment, how to stop the treatment, and what happens if you do not go ahead and stop the medications. Next slide shows that why we should stop the treatment. In the past, we have always thought that reflux in babies is self-limiting, so we can probably eventually, after a few months, get the children off acid suppression. But the dogma in the past was that reflux in older children was a lifelong condition, and people needed to be on treatment for the rest of their life, or at least for many, many years. And then the group in Italy from Dr. Saiano and Boccia published a very elegant study. That's probably the most definitive study that looks at the need, whether or not somebody needs to be on maintenance treatment. What they did, they took 48 children that had erosive esophagitis, and they induced remission in all of them. They healed erosive esophagitis with appropriate PPI treatment. And what they did after that, they randomized patients on H2 blockers, PPI, and placebo. And after 3 months, they rescoped them. And they found that the patients on placebo were doing just as well as the patients on PPI, kind of suggesting that you can stop the treatment. And what they did then, they monitor all of them. They follow up 44 of the 48. They monitor all of them for 30 months. They did not rescope them, but they monitor symptoms. And only 3 had very mild GERD symptoms after 30 months. So this study suggested that, yes, even in older children, you can get them off PPIs, off acid suppression, probably in the majority of patients. Next slide shows how to stop, right? Once we've figured out that, yeah, we would like to stop, let's see in the next slide how to do it. This was also a very elegant study. This is a study that was done in adults, so that, we don't have similar data in children, but it's a study that makes a lot of sense. What these investigators did in Scandinavia, they randomized adult asymptomatic patients, so adults who did not have reflux symptoms. They gave them pantoprazole. They gave them pantoprazole at a dose of 40 milligrams a day. And as you can see in the in the x-axis, you can see all the weeks and how long they were on. After 6 weeks, they stopped the treatment, and they monitored the symptoms. Every week, the patients were completing a diary. And what you can see is the patients who were on a PPI compared to the patients on placebo had a much higher prevalence of dyspeptic symptoms, which makes sense, right? There is a hypergastrinemia that occurs whenever we shut down acid secretion in individuals that take PPI. Once you stop the acid suppressive medications, there is a rebound hypersecretion because the patient has high gastrin levels. And the rebound hypersecretion makes you not feel well, and it causes dyspeptic symptoms. So this is almost like a medication that has caused a need for itself, because you need, after stopping it, if you're stopping it suddenly, you have worsening of symptoms. So you probably need to wean the patients, or at least provide some anticipatory guidance that for a couple of weeks after stopping the medication, they may not feel great. What this study has done for me is it changed the way how I stop the medications. I used to stop them cold turkey, and now I actually wean patients. I go from BID to once a day, or from once a day every other day, or decrease the dose. There is really no right or wrong way to do it, but you want to probably give some thoughts about not stopping the medications suddenly. Okay, in the next slide, we're actually going to see what are the possible risks of prolonged acid suppression. So far we've figured out why we need to stop it, how to stop it. Let's figure out what happens if we don't stop it. This is a fairly comprehensive table. Actually, this table gets longer almost every week. There is a new publication about possible other risks related to PPIs. But this is a table that summarizes the most studied possible long-term consequences. One is infections. C. difficile, bacterial overgrowth, other enteric infection, pneumonia have been shown to be more prevalent in patients on acid suppression, and we'll discuss that in more details. Necrotizing enterocolitis, there is some signal that may be more common in patients with acid suppression. There may be some effect on vitamins and mineral absorption because some of these minerals are better absorbed in an acid environment. Then there is the very common findings of gastric funding gland polyps, which have no malignant potential, and they are probably just a nuisance, an epiphenomenon, but have no pathogenic potential. And then there are some rare idiosyncratic reactions such as interstitial nephritis, and I will show with my last slide of my presentation some of the data related to myocardial infarction. Next slide shows a review paper that was published a couple of years ago that summarizes some of the data related to pediatric consequences of PPI or prolonged acid suppression in children. And as you can see, the location of these studies is mostly in the ICU, either the neonatal ICU or the pediatric ICU. So that also gives you a sense that these are patients that have high prevalence of other comorbidities, are fairly sick. So this is a very special type of population. The findings in this type of population may not be applicable to the rest of the pediatric groups. And you can see in the outcome assess column here is that most of the consequences were infectious or inflammatory consequences, such as ventilator-associated pneumonia, increased risk of nosocomial infections, increased risk of other infectious problems. In the next slide, we see why people suffer from more infections. You know, to be honest, until I prepare for this presentation, I always had a fairly easy thought that, of course, you have no acid. Acid is a good barrier. You get more infections because of that. But it's actually more complicated than that. There is evidence that the microbiome is altered, and altered microbiome in response to prolonged acid suppression causes mucosal inflammation, may cause bacterial translocation, and increased permeability. There is also evidence that PPIs work on the immune response, and that's why there is maybe a subset of eosinophilic esophagitis patients that respond to PPI, because there is an effect of PPI on immune cell surveillance, activation, migration, and function. Finally, actually, there may be some direct effect on the bacteria that lead to decreased effectiveness of antibiotics, because there are some antibiotics that need to be uptaken by the bacteria, and PPI may affect microbial enzymatic activity. So there are multiple reasons why more infections can occur in children who are placed on long-term acid suppression. The next slide actually shows the most conclusive side effect of prolonged acid suppression: increased prevalence of C. diff. You know, this is so well demonstrated. The FDA is actually now putting on the prescription information that there is an increased risk for C. diff in patients on PPI. The initial retrospective study showed that actually patients treated with PPI had an increased odds ratio of 4.5, which is a dramatically increased odds ratio. And obviously, if you use PPI and antibiotics, the risk is further increased, while H2 blockers may actually be less harmful. So there is, people have done multivariate analysis that suggest that, H2 blockers, a once-a-daily PPI, increase the risk slightly, but more frequent PPI, like we used to do in the past, actually can increase the risk by 2, 3, 4 times. The next slide shows that other infections are equally increased in patients with prolonged acid suppression. People have done studies that have looked at increased risk to contract Campylobacter or Salmonella infection, and there is an increased risk, even though not as high as for C. difficile. Interestingly, a study that was published recently by Rachel Rosen has also shown that use of PPI changes the microbiome not only in the intestine, but also in the stomach, in the pharynx, in the larynx, and that can lead to the paradoxical consequence that PPI, which often are used to treat pulmonary consequences of reflux, may make those symptoms worse because may actually be associated with more respiratory symptoms. Interestingly, I'm part of an aerodigestive clinic, and as you can expect, my ENT and pulmonary colleagues push aggressive treatment for reflux for everybody. And now that I've shown them that actually PPI may cause respiratory problems, I get a lot less push to proceed with such an aggressive treatment. The next slide, in fact, shows other possible consequences. There was a study done in Italy, which actually has not been confirmed by other authors, but this study suggested that even necrotizing enterocolitis risk may be increased in patients with acid suppression. In this case, was an H2 blocker, was ranitidine, was not a PPI, but the concept is the same. Patients with acid suppression, because of the change in microbiome, because of the change in possibly bacterial translocation, may be at risk for necrotizing enterocolitis. Next slide shows that bacterial overgrowth may be another consequence of prolonged use of PPI. This was a study that looked at the patients who were placed on PPIs for other reasons, not for bellyache. Were placed on PPI for 3 months, and then the authors found that, you know what, some of the patients with PPI on prolonged PPI use had developed abdominal pain, bloating, flatulence, belching, and they were able to demonstrate that those patients actually had developed bacterial overgrowth. The next slide shows that what I already mentioned before, that there is a risk of increased respiratory infections in some of these patients, and in fact, there was a beautiful study that looked at the use of PPIs in asthma, in patients with asthma without reflux symptoms. And what these authors found was that the use of PPI did not improve symptoms, nor improve lung function, but actually increased respiratory infections. And there are studies that have used PPIs for treatment of babies with symptoms suggestive of reflux that have shown the same thing. Basically, what they've shown, what these studies have shown, is that you do not treat what you think you're treating, but actually you're causing more problems with more respiratory infections. And there was also a very intriguing study in the past that looked at the use of PPI prenatally in pregnant mother and found that the children, the offsprings of these mothers, were at higher risk to develop asthma and other respiratory problems. This has not been confirmed, and there is not really a clear biologic plausibility that explains this, so I'm not quite sure that that will stand the test of time. The next slide transition to other possible consequences of prolonged use of acid suppression, which is what is the effect of the lack of acid, gastric acid on the absorption of minerals and vitamins. And I picked only two. I picked only iron, which is in the next slide, and then calcium. There is some evidence about magnesium and vitamin B12 as well. So this was a study done in adults who were on PPIs for 1 year and had pre and post PPI use hematologic indices being checked. And as you can see here, there was a minor but detectable, still statistically significant, decrease in hemoglobin, hematocrit, and MCV in patients on prolonged PPIs. I'm not sure what the clinical significance of a decrease in hemoglobin of 0.2 or a tiny decrease in hematocrit, but nevertheless, there is some evidence that that's the case. And interestingly, people have published a study last week on hemochromatosis, kind of pointing out the opposite, that the use of PPI decreases the need for blood removal, for removal of your red cells. Next slide shows the risk of hip fracture. This is a meta-analysis, two meta-analysis done by the same authors. The top panel looks at PPIs, the bottom panel looks at H2 blocker, and as you can see, both panels show that there is a slight increase in hip fractures in adults. This was a study, all studies done in adults, with the PPI seemingly be a little bit more dangerous or more harmful than H2 blockers. There are a lot of problems with these studies. As you can see, some studies actually cross the vertical line, so they are not statistically significant, and only when you do a meta-analysis of all these studies, you can actually detect a statistically significant difference. And in fact, there was no correlation with the duration of use of PPIs. Many PPI users had lower bone density at baseline, and there is also conflicting more recent evidence that did not confirm this data. The next slide actually shows the only study that I was able to find in children, a study published in a few months ago, and this study looked at young adults between 18 and 29, and it was able to detect a small increase in risk factor for fracture associated with PPI. But when they looked at children less than 18, and this is the table that reflects that data, children younger than 18, and if you look at the very bottom part, the cumulative exposure up to 720 doses, the confidence interval between 0.9 and 0.95 crosses the 1. And in fact, you can see that the total, when you analyze all the data together, the total adjusted odd ratio is 1.13, with a confidence interval of 0.9 to 1.3, so not statistically significant. To be honest, probably more studies need to be done on this. Probably needs to be looked at children prepubertal, children going through puberty, and see if that data applies to those children as well. The next slide actually is the one that relates to the risk of MI, myocardial infarction in adults on PPIs. This was a study that got a lot of press, even generated a statement from the ACG and the AGA, because as you can imagine, this is something that catches people's attention. And there is some biologic plausibility because there seems to be some reduction of nitric oxide levels in the endothelium, in the vessels, that at least can be demonstrated in animal studies. So you can make the case that maybe that could put you a little bit more at risk for an infarction, for MI. And I want you to look at the top one or two panels. The first panel shows that the PPI are associated with a slight increase in MI, but somewhat surprisingly, H2 blockers almost seems to be protective, which seems really odd to me. The panel B actually shows that only 3 of the 5 commonly used PPIs are associated with an increased risk of MI, which also seems a little odd, although that's what they reported. And the third panel, panel C, shows that the increased risk of MI was just the same in younger or older individuals, and whether or not people were on anticoagulants or not. So, the data about MI are very much, need to be confirmed. The next slide actually shows that this was really data mining exercise, and when you do that, you query, 60 million clinical documents, you are kind of due to find even a very marginally statistically significant difference in almost anything. In fact, the absolute increased risk was very minor. For every 4,000 patients treated with PPI, only 1 would develop an MI. And there are a lot of other confounding factors, right? There are a lot of other features of GERD patients who take PPI that may also lead to an increased risk of an MI, such as obesity and smoke and so on. And there was really no correlation between the dose or the duration of PPI use and increased risk of MI. So I'm not in any way convinced that this is a true association. So, in summary, the last slide kind of summarizes what has been discussed in the last 15 minutes. As you can imagine, as you can understand, it's true about every drug we use. Prolonged acid suppression should be used only when indicated. But once you start thinking of when and how to stop the treatment. Begin to discuss with the parents for how long you want to treat it, and eventually how you want to get your patients off acid suppression. Nevertheless, there is evidence in children that there is a true increased risk of infection, especially with C. difficile for those treated with a PPI. And I would say that at this point, with the current state of knowledge, other risks demonstrated in adults have not yet been confirmed in children. And with this, I'm going to pass the baton to Jen to wrap it up. Hi, Jennifer.
Thanks, Carlo. So with some closing thoughts, I wanted to revisit the question we posed, which is PPI to use or not to use. And actually, I want to ask, is that the right question? I think it's very important to ask is that the right question? And the answer is not really. Perhaps we're hoping, as a field, we start to tackle more important questions, which is, as we're treating with PPIs, we're asking if it's indicated and evidence-based. And then, very importantly, we're thinking about how long treatment will continue. Next slide. So our take-home messages, if I could sum it all up, is that PPIs have a role in NERD and hypersensitive esophagus, but not in functional heartburn. There is very limited evidence for using PPI in extraesophageal conditions, such as asthma, cough, and ENT, that are associated with reflux disease. When there is evidence and there's appropriate use, they should be used. I think PPIs are appropriate and indicated in erosive reflux disease, NSAID prophylaxis, bleeding, PPI-responsive esophageal eosinophilia, and H. pylori eradication, but always for a defined period of time. And ongoing management should include a plan for treatment discontinuation, and that has to be particularly done with full education of both ourselves as physicians and also of our patients of the risks that are associated with PPI therapy. So we're now going to take some questions, and we've been pleased to see some come in, and we're going to do our best to get to as many as possible. As a reminder, the question area is located directly beneath the webinar player window, and you may need to scroll down to see it and to send in your questions. So I'm going to start with the first question, which came in, and I'm going to direct this to you, Rachel, if you don't mind, which is, what about an inflamed esophagus that doesn't have erosions? Is this still NERD? And when you discuss this, could you also clarify, when we talk about erosive, does this mean visual endoscopic mucosal breaks, or does microscopic inflammation suffice?
Great. Thanks, John. So when you're looking at the definitions, and again, keep in mind that these definitions are adult definitions. The definition of erosive esophagitis is visual erosions. You need visual erosions, and that is, by definition, a requirement. Now, what's really interesting is, as pediatricians, we biopsy the esophagus, whereas the adults hadn't prior to this evolution of eosinophilic esophagitis. So now we have a whole group of patients who have no visible erosions but have microscopic inflammation. So then the question is, what bucket do these people fall into? Do they fall into the erosive group, even though you don't see any erosions because there's inflammation there, or do they fall into the non-erosive group? And how does this microscopic inflammation influence treatment patterns? So I can give you a little bit of insight. Both there's pediatric and adult literature on this, and I'm just going to review this briefly. So starting back in 2013 or so, there's adult literature looking at microscopic inflammation in NERD versus erosive disease. And this first study was in APT in 2013, and they looked at a variety of inflammatory characteristics: papillary elongation, basal cell hyperplasia, dilated intracellular spaces. And when you look at the histology, the biopsies of NERD patients look identical to the biopsies of erosive patients. So the rates of inflammation in this initial APT study showed that their rates of microscopic inflammation are exactly the same, so we can't differentiate them. But when you look at the functional heartburn patients, they have much lower rates of inflammation by biopsy. Following up on this, there was a study in 2014 by Savarino that looked at patients with erosive esophagitis, hypersensitive esophagus, functional heartburn, and they looked at their rates of microscopic inflammation. When you look at the rates of microscopic inflammation in erosive esophagitis, it's about 95% of adults. When you look at the NERD patients who are pH probe positive, it's about 77%. When you look at the hypersensitive esophagus, it's even a little bit lower, 65%, and then functional heartburn, only 13% have microscopic inflammation. So while the inflammation may help you for the functional patients, all of the other groups are very much overlapped. Now, there is one pediatric study that looks at the differences in histology in patients with non-erosive reflux disease versus erosive disease that was in Neurogastro and Motility in 2012. And what they found was that the NERD patients in these pediatric group of, again, the population was 15 patients, 47% had microscopic inflammation. And in the erosive group, it was 91%. So there was a significant difference in the rates of microscopic inflammation. But as you can see, even in NERD patients, they have microscopic inflammation. So while these are all great descriptive studies, it doesn't really answer the next question, which is, when you have inflammation, does that predict that you're going to respond to proton pump inhibitors better from a symptomatic perspective or not? And that data is not known. So we're just starting to describe the inflammation, but we don't know for the true NERD patients, does microscopic inflammation predict prognosis? So lots of research still to do in this area.
Great, thanks. So Jose, if you don't mind, I'll aim number 2 question at you. What is your position of PPI use in NICU babies with apnea and bradycardia? And the question poser was pointing out that this is a common consult that many of us deal with.
Thank you. Yes, it's definitely a common consult. So if you look at data that has been published, apnea and bradycardia are going to be more common in premature infants and are going to be more associated with a lack of maturation of aerodigestive protective reflexes more than actually reflux disease. And patients that have apnea and bradycardia can have it with swallowing, can have it with reflux, or can have it without actually no esophageal pattern going on by impedance or manometry that's shown in NICU infants. And above all, even those that are related to reflux, also very robust data by multiple papers show that in infants, acid or non-acid are both as likely to cause symptoms. So the correct answer is no, PPIs are not going to help the apnea and bradycardia according to the evidence base that we have at this moment.
Great. So Carlo, asking you a question, what about utility of PPI for children with severe unexplained dental erosions?
Yeah, actually, that's an excellent question. The literature on dental erosions is actually a lot stronger and has a lot more evidence than the literature regarding a lot of other non-esophageal manifestation of reflux. So I believe there is a role for acid suppression in those patients. Interestingly, the group of Rachel Rosen, I think in the next issue of JPGN, has a paper showing that acid reflux and not necessarily non-acid reflux is associated with tooth erosions. The only problem I have in those patients is for how long. You know, let's say that you have a patient with unexplained dental erosions that are likely to be related to reflux. How long are you going to treat them for? So I have to be honest with you, I do treat some of those patients. In order to see a benefit, it's probably going to take months or years. And those are patients that who probably you need to treat for a prolonged period of time. So you need to really weigh really well the risk and benefit of prolonged treatment. But there is certainly a role for acid suppression in those patients.
Okay, well, honesty counts. So with that same question, I'm going to move to Ben and pose the question that came to us, which is how to approach the patient with intractable asthma that's been referred to you. If a rare patient does respond to PPI, is it worth trying it? Is it worth a trial?
I think that's a question that we all wrestle with, Jen. And one of the points that I tried to make in the presentation, and that in fact, if you read carefully the discussion in both the New England Journal paper from the Adult Asthma Lung Consortium and in the JAMA paper from the Pediatric Consortium, and actually in a investigator-initiated trial that we did, was that there are a select group of patients that do respond. In the adult trial, it tended to be those with GERD symptoms and that had a positive pH metry using the, now we should call it the Rosen technique, by doing the pH metry with impedance off therapy. If you're going to, it isn't going to hurt. Yes, it is certainly safe, but I think if you're going to try to use a therapeutic trial of a PPI in a patient with intractable asthma, I would have very specific endpoints that you're going to look at, very specific criteria that you're going to look at in terms of whether they're symptoms or object measures such as asthma lung function or symptom scores. There's actually a validated both symptom score and quality of life measure that Juniper has used and published on and has the proprietary rights to. She's in the UK. And objective measures like, again, pulmonary function tests. But if you're going to do it, make sure that you've got objective measures and that you do it for a definitive time period, so 8 weeks, 12 weeks, and then you wean them off. And I would say in that case, if you see in that particular patient that there's a treatment benefit, then you've basically proved it. And that's how I would address that. So to summarize, clear endpoints that you're going to look at, a defined duration of therapy, and an exit strategy in terms of the therapy that you're going to use.
Okay, terrific. So moving to, I have lost my questions. Moving to, I think, a very important question. I'll ask Carlo if you can talk about how long it is safe, or how long do we think it is safe to be on a PPI? And is this something that one can do for a lifetime, let's say with PPI responsive esophageal eosinophilia?
Yes, I think there is no such a thing as an unsafe duration of treatment. Some of those consequences, especially the ones on mineral and vitamin absorption, may be related to the duration of treatment. Well, we don't even know that. Let's put things in perspective here. PPIs have been around 20, 30 years now, and there is really no conclusive evidence that they cause any life-threatening problems, despite my presentation. So I would feel very comfortable in either being myself on PPIs for many, many years or putting somebody on PPI for many years. Now, eventually you have to make a decision if somebody needs to be on very prolonged PPI use, whether or not they're better off getting a laparoscopic fundoplication, which is really not a huge deal anymore nowadays. But if they decide to go with PPIs, I would be certainly comfortable or use it for as long as needed.
Okay, great. And I think we have time for about one or two more. So, Jose, I'm going to pose a question to you. Is there any role for PPI for prophylaxis while on steroids?
Well, I think that although it would make sense, sadly there are no, my task was to do evidence-based therapy for PPI, and there's no data that says that we should or we should not. I think common sense says that a lot of us actually do it when we're putting patients on steroids, but I can't answer with data about it.
Okay, that sounds fair. How about, Ben, I'm going to pose to you, what is your approach to management of gastric fundic gland polyps in a patient who's PPI dependent? Do you worry about those gastric fundic gland polyps? How about all the other stuff, actinic cell hyperplasia, glandular dilations, all those things the pathologists point out to us?
Right. So good question. Carlo actually touched on this only briefly in his very data-rich, nice presentation about the risks of PPIs. I think the person that really deserves a lot of the benefit in terms of bringing this issue to the forefront, publishing on it, and looking at a long-term series is Eric Hassel, was at the time at BC Children's in Vancouver. And Eric actually had a cohort of patients that was originally enrolled, and actually his reference was cited by Jose in his talk, a Canadian and European erosive esophagitis trial. And these patients were on omeprazole, and some of them were on pretty high doses, 3.5 mg per kilo per dose twice daily. And he was the one that first described, particularly in the cardia of these patients, the fundic and cardia polyps and ECL hyperplasia. The key take-home point was, if you look at Eric's series, which he has published on in a number of circumstances, the long-term risk for dysplasia or even carcinogenesis was really not found. Ernst Kuipers, who's a pathologist from Scandinavia and has been looking at gastric pathology, particularly with respect to H. pylori for many, many years, has also looked at long-term use of PPIs, both in H. pylori infected and H. pylori negative patients, and again did not seem to find any long-term risk of carcinogenesis with respect to the PPI. So it's a finding. One of the other points that Eric has made in his papers is that if you reduce the dose of PPI and or you wean them off the PPI, those go away. So that would be my take point.
Okay, so I'm going to move us to the last question, but before I do, I want to acknowledge that we didn't spend time in this webinar talking about diet, which may have been an oversight. I think the role of diet has been so well shown in infants that, again, as pediatric gastroenterologists, I think we know that lifestyle changes in diet, in particular changing diet of a breastfeeding mother or changing a formula for formula feeding infants to extensively hydrolyzed formulas in infants and avoiding certain allergens in moms actually can really help with reflux. Unfortunately, I think there is just not great data out there on both adults and children on nutrition, so we did not include that, and I will acknowledge that. And as a final question, I'm just going to go back to Rachel and ask if you could just talk a little bit about data that might support a certain duration of therapy for NERD or hypersensitive esophagus that improves on PPI, and also, is there any way to say how long you go ahead and treat NERD and what is your endpoint?
Right. So that's a great question, and the answer is, for us, there's really not any data. I can just give you my biased opinion, which is the beauty of NERD compared to, for example, Ben's subject, is that for NERD you actually have concrete symptoms. So you know that when you wean the med, you'll get symptoms back, which is a lot more concrete than, say, the patient who's having changes in pulmonary function testing, or for the patient who has chronic hoarseness, for example. So at least with the typical symptoms, when you wean the PPI, you'll know if the symptoms come back. And when you look at the adult treatment algorithms, the treatment algorithm is really driven based on symptom response. So, there's a lot of debate. Should you be scoping them? What are you looking for? And as we've talked about, their scopes are essentially normal, or you may have some microscopic inflammation. So you don't need to do necessarily serial scopes to see should you wean your PPI or not. You're really going based on symptoms, and that's why you're treating. So my answer to that is, and my practice is that I typically try to wean once a year and see if I can at least get them on a lower dose to try to avoid the side effects that Carlo had mentioned. The idea that we keep patients on long-term is really tricky, and we don't do it anymore. So we try to aggressively wean, and if the symptoms come back, we put them on, and that doesn't mean you need to rescope. You just put them back. And again, that's not based on data, but my own opinion.
Perfect. Okay, well, I'm going to bring us to a close, and again, want to thank the attendees and certainly the faculty for participating in today's webinar. It was an ambitious agenda, but we seem to have hit our targets. We will be posting a recorded version of the webinar on the NASPGHAN website, www.naspghan.org, in a few days. In the meantime, and certainly as a reminder, you can obtain CME credit through the link posted on the registration page, and you can also go ahead and download the PDF version of the slides. Feel free, please, to have these slides. You go to the link beneath the webinar window. I just want to thank again NASPGHAN and the NASPGHAN Foundation for sponsoring this program, as well as to AstraZeneca for providing support, and I want to wish everyone a great night. Good night.